Our next speaker is Dr. Loevner. She's well known to the audience by now. Just a quick introduction. She's a distinguished neuroradiologist with training, currently a professor at University of Pennsylvania, trained scope medicine, UPenn, and further training in UPenn and UMichigan, and with over 170 peer-reviewed publications, presentations. She's an international figure with special interest in MRI imaging of head and neck cancers and neurological conditions. So without further delay, it's all to you, Dr. Loevner.
Okay, good morning, everybody. I am delighted to speak to you today. And we're going to really be talking about two important things when you're dealing with head and neck cancer. One of them is going to be fixation to the paraspinal or prevertebral musculature, which basically renders you inoperable. And I don't know how many of you have seen a carotid blowout, but I've seen many of them, and it's a very devastating thing to see, and we're going to address that afterwards. So we're going to look at head and neck carcinoma today relative to its fixation to the precervical fascia, or encasement of the carotid artery, and we may be talking about the primary tumor or a nodal mass. Both of those render you inoperable. And then we're going to talk about carotid blowout syndrome. And the important thing to recognize throughout this talk is we want to emphasize the impact of these two important entities regarding surgical candidacy and management, and also prognosis. So the normal prevertebral fascia is encompassed, it's the deep layer of the deep cervical fascia, as you see here. And you'll see in red here the deep layer, the deep cervical fascia enveloping the vertebral body, as well as all of the surrounding prevertebral and paraspinal muscle. It's important to recognize that the prevertebral compartment extends from the skull base all the way down to the mediastinum. There is a nice retropharyngeal fat pad that typically exists between your tumor and the prevertebral fascia. And here you'll see the spinal column, the longus colli and capitis muscles. This is the constrictor muscle, and between them, the white arrows denote that precervical fat pad in the retropharynx, again, anterior to the prevertebral muscle and posterior to the constrictor muscles. And remember yesterday, we talked about the retropharyngeal fat, and when the retropharynx is normal, it's really just a potential space, and all you can see is this tiny fat pad anterior to the prevertebral muscles and behind the constrictor muscles. So prevertebral fixation and or invasion is really important to try to identify prior to management, especially surgery. If it's clearly present, and you can say that on your MR image, then you're inoperable and often incurable. So you're going to be undergoing a lot of palliative and temporizing measures for therapy. If fixation may be present based on your imaging, then the patient goes on to be clinically assessed at panendoscopy, and if they pass manual manipulation at panendoscopy, they may go on to surgery, and in the operating room, they will again be assessed manually for mobility of the tumor relative to the precervical fascia. If prevertebral fixation is absent on imaging, which is a nice thing to be able to detect, then you are an excellent surgical candidate, providing that the other factors on imaging and clinically are favorable for surgery. So again, this is the normal retropharyngeal fat between the prevertebral muscles and the constrictor muscles of the pharynx. This is a flagrant case of prevertebral invasion and inoperability. You'll see obliteration of the fat pad. You'll see not only the primary oropharyngeal tumor, but also the nodal mass directly invading the prevertebral muscle, which is enlarged, abnormal in signal on T1, diffusely abnormal in signal on T2, and demonstrating solid enhancement. So this is an easy case. This is prevertebral invasion. It's beyond fixation, and this is a person you can render a non-surgical candidate. But what do you do in advanced pharyngeal tumors when that retropharyngeal fat is obliterated and maybe only one of the findings is present? How do you know whether it's fixed or not? So we did a paper and we looked to see if MRI could predict prevertebral involvement. We looked at irregular tumor muscle interface, compression or concavity of the muscle, signal abnormality in the muscle on T2, and enhancement. All these patients underwent endoscopy to look for manual manipulation and mobility of the tumor relative to the prevertebral musculature. And I'm just going to go back at advanced. And 40% of these patients were actually fixed at panendoscopy and deemed inoperable. 60% of the patients' tumors were mobile at endoscopy, and when they went on to surgery, 78% of them were resectable, which means sometime between endoscopy and surgery, the tumor progressed. You really want to try to have, more than 2 weeks between endoscopy and surgery. The MR criteria that we just saw were compared with the endoscopic findings in all patients and the surgical findings in those that went on. And what you can see is those individual findings: high signal intensity, muscle enhancement, the contour between the tumor and the muscle. None of them were both sensitive and specific. They actually had very poor specificity, as you can see, 14%, 29%, and the accuracy is each of these individually was 53 to 60%. So when you see all of them present, you know there's fixation or invasion, but you can't use a single criteria once you've obliterated the retropharyngeal fat. We're just not good at it, and it's much more important to give the patient the benefit of the doubt and get them to the operating room and let them determine that endoscopically or at surgery. Here's a posterior oropharyngeal cancer. We can see that the retropharyngeal fat is indeed obliterated. The muscles and everything else looked okay. In panendoscopy and at surgery, the tumor was mobile on manual manipulation and it was resected. These are two different patients with right oropharyngeal cancers. They both have obliteration of the fat pad, irregular tumor muscle interface, and concavity of the prevertebral muscle. Here you'll see a tumor, a retropharyngeal node. Here you'll see the normal fat, right? The retropharyngeal fat anterior to the prevertebral muscle. It's obliterated here. The muscle is concave and compressed. This was fixed and inoperable. Here's a different patient with a real large right oropharyngeal tumor. Same findings: obliteration of the fat, irregular contour, concavity of the muscle. This one was completely operable and resected. Now here's the good news. So when you're completely abnormal on imaging, we can predict it. And here's the other piece. We looked at patients, 75 patients with advanced tumors, and we looked for preservation of the retropharyngeal fat. And if the fat was preserved, we wanted to make sure that there were no abnormalities in the adjacent prevertebral muscles, namely T2 hyperintensity and enhancement. We found that 40 of the 75 patients with preserved retropharyngeal fat, all 40 had normal muscles on T2 weighted and enhanced imaging, and 39 of those 40 were resectable. The one that wasn't, there was probably progression of tumor between panendoscopy and the operating room. Here's a nice example of absence of fixation. You'll see the left oropharyngeal tumor, nice clean retropharyngeal fat. Again, the oropharyngeal tumor, and nice clean fat. Here's cervical nodal metastases. So not only do you need to look at the primary tumor, but if you have an inoperable neck, then you have an inoperable primary. So when you have large lateral tumors that invade the prevertebral or the paraspinal muscles, as is clearly evident here, you are inoperable. This is a high cervical lymph node encasing the internal carotid artery here and also invading the muscle. So this lymph node is invading the prevertebral muscle. That is obvious. It is also encasing the internal carotid artery. That is another contraindication to surgery. So both of these are contraindications to surgery as you move on. Here's a patient here with a high cervical lymph node, invasion of the prevertebral muscle, in fact, the paraspinal muscle, and encasement of the carotid artery. When the tumor encases the carotid artery by 270 degrees, it's got a high predictive value that the artery is invaded and usually renders the patient inoperable. This is a lower cervical nodal metastasis encasing the common carotid artery on the right. It was also invading the thyroid gland, and this is another inoperable tumor. So now moving on to carotid blowout syndrome. Carotid blowout syndrome is a head and neck cancer complication, and in the vast majority of patients, no matter what series you look at, it's related to radiation. So the first thing for anybody that's training, most carotid blowouts are not from tumor invasion. Most carotid blowouts are related to sequela in the tissues from radiation and treatment. Some of them have had surgery, radiation, and chemo. Additional risk factors that put you at higher risk for having a blowout: mucocutaneous fistulas, soft tissue necrosis, wound infection, poor nutrition and poor wound healing, and re-irradiated patients. So patients get re-irradiated. So Patwitsky looked at the clinical manifestations in patients with carotid blowouts that had radiation. 38% had infection, 40% of those patients had mucocutaneous fistulas, and 55% had soft tissue necrosis in the tissue around the imploding artery. Now, this is a cervical carotid blowout. These are less, in-your-face kind of bleeds. This is someone that's had a laryngectomy with a flap, and we can see this gigantic pseudoaneurysm that presents as a rapidly expanding neck mass, but they're not bleeding out in front of your face. These are a little more manageable because you're not exsanguinating into an open space where the blood is just spewing out. The soft tissues tamponade that pseudoaneurysm that is growing. Now, these are different. This is the CT and the CTA findings associated with a threatened carotid blowout. So when you're reading irradiated necks, you better be paying attention to the vessels. So this is a patient here, things that you want to look for that suggest that the patient may be at risk down the road for a blowout. You want to look for a soft tissue mass encasing a vessel. That vessel is typically focally narrowed and irregular. Here is the vessel, the external carotid artery. You see the soft tissue mass. If you look here, you see the irregularity of the external carotid artery. And also, if you have associated internal jugular vein thrombosis, that puts you at higher risk for having a carotid blowout. The other things you want to look for are tissue necrosis. So this is necrosis in the submucosal tissues, and if you look very closely, you will see there's a pseudoaneurysm, we call that the nut sign, coming from the carotid artery. This is a different patient. You see an inflammatory mass around the precavernous internal carotid artery. Don't give up looking. If you keep looking here, you'll see there's a little nut here, a little pseudoaneurysm coming off, and both of these pseudoaneurysms are exposed to the mucosal surface and the widely open airway. So nothing to tamponade it if it ruptures, and these will result in oral and nasal bleeds. Those are sentinel bleeds that may go on to blowouts. So let's talk about the clinical presentation of carotid blowout. Threatened. A threatened blowout means you have an exposed carotid artery or whatever arteries at risk, and or you have CT or CTA evidence of involvement, vascular encasement, soft tissue encasement, irregularity, a pseudoaneurysm, soft tissue necrosis. In these patients, hemorrhage is likely inevitable over time. It doesn't mean it's going to happen tomorrow, but it means you should, probably treat it while you have the time to casually do so. An impending carotid blowout is when you have an acute oral or nasal bleed, we call that a sentinel bleed, that spontaneously stops, so it stops. That's an impending, and then obviously an acute blowout is when you're blowing out and you have uncontrollable hemorrhage because the vessel has ruptured, and the ones that are very devastating are the ones that blow out into your aerodigestive tract. So let's look, here's a patient with adenoid cystic carcinoma. They were radiated in 2016. They had nasopharyngeal squamous cell carcinoma in 2020 and were re-irradiated in 2021. In 2022, they had their routine surveillance imaging, no recurrent tumor. We just see some inflamed mucosa. This looks really quite healthy, no masses here, good-looking nasopharynx and upper oropharynx. Fast forward to March 7th of 2023. The patient comes in with intermittent multiple nosebleeds that are spontaneously stopping. That is the sentinel bleeds, the impending carotid blowout. And if you look at this patient, you'll see that the carotid artery is narrowed. It's encased, right, by a new soft tissue mass. We didn't see that, right? The airway's indented. And if you come down here, again, you'll see the necrosis in the tissues. And if you come up close, again, here is your pseudoaneurysm coming off the vessel, exposed to the necrotic tissue and the aerodigestive tract. So what happens? Next day, boom, carotid blowout, blood pouring out everywhere. What you do is you pack the mouth really densely with gauze to tamponade the bleeding. So that's what you do. So the mouth was packed with gauze. They came down to the angiography suite. When the catheter got advanced in, the gauze was removed, the vessel was injected, and you can see here the exsanguination, the blood coming out. And then what ended up happening here was the patient passed a balloon occlusion test and went on to have the pseudoaneurysm stented. So we call that constructive repair. This is a 56-year-old with nasopharyngeal cancer treated with chemoradiation, also having episodes of epistaxis, so the impending carotid blowout. And you'll see this patient here has a soft tissue mass around their horizontal petrous carotid artery. If you look very closely, you can see there's extra nuggets there. These are the pseudoaneurysms, and they again are projecting directly to the airway. Here is the CTA and the angiogram showing the pseudoaneurysm and the marked irregularity. This patient was stented before they blew out. This is a 75-year-old with neck swelling. So she came in with neck swelling. Nobody thought of a hematoma here, to be honest with you. I don't know, it was read as radiation change. 5 days later, in they come with oral bleeding, airway compromise, and their acute carotid blowout. You can see this big pseudoaneurysm here, continuating the airway where it was bleeding into, and the angiogram here. And fortunately, this was also treated with construction, which means stenting. This is a patient that we just saw a few weeks ago, esophageal cancer, treated with a radiation multiple times, surgery, came in with transient bleeding from their tracheostomy and impending carotid blowout. It spontaneously resolved. This was the CTA they had, and unfortunately, you'll see there's abnormal soft tissue surrounding the common carotid artery. If you're astute, you'll see that there's a little nugget there. There's a pseudoaneurysm coming off the lateral wall, and it's going through the soft tissues, and 2 hours after this, the patient had a carotid blowout and died up in the room. They couldn't make it back down to surgery. So again, had this been found, I think it would have been treated. So very important, every radiated patient, even if they're not bleeding, I check this in every single patient I'm looking out. So endovascular management, stent placement is called construction. Occlusion, we call deconstruction, and if you're going to take out the common carotid artery, the internal carotid artery, if you have time, i.e. the patient's not bleeding in front of your face, you do a balloon inclusion test, you inflate it in the carotid artery, you test the patient's neurologic status over 30 minutes. If they have no deficits, it means they're at lower risk for having a stroke when you sacrifice that vessel. External carotid blowouts are treated with deconstruction. You just occlude the vessel. So, all right, in our last image, and we're going to finish a minute early. So if you have a stabilization, this is the management of carotid blowout. If you can have an impending bleed, so that sentinel bleed that stops, or you have an active bleed and you can stabilize the patient with packing, you want to try to do endovascular treatment. Most of these patients have had a CTA already. Now, if you're at a place where there's no possibility for endovascular treatment, if you can transfer the patient safely, transfer them. If you can't, then you just take the vessel. You have to take care of the patient first. If you are stabilized and can be transferred, or if you're in an institution where there's endovascular capability, then you want to look at the clinical subtype. Is the patient impending bleed, meaning they had a sentinel bleed, it stopped, and they're not actively bleeding now? Or are they acutely bleeding and they've been packed? And you go on to angiography. Again, if it's an external carotid artery branch, we just deconstruct. You just occlude the external vessel that's involved. But if it's the common carotid artery or the internal carotid artery, what you really want to try to do is a balloon occlusion test if the patient's not actively bleeding. If they pass the test, then you can go on and take the vessel, because sometimes when you put the grafts and they end up rebleeding down the road. So that's the best thing we like to do. But if they don't pass the balloon occlusion test, then we will try to put a graft in. Remember, there is that cohort of patients that are actively bleeding, and sometimes you just got to bypass the balloon occlusion test and embolize the vessel, deconstruct, which means no graft, just take the vessel. Thank you for your time. Hope you don't see one of these, by the way.